Hello everyone, a very good afternoon to all of you, and it's good to see people face to face after a long time. And we are going to begin the ASRS AIOS session, which the ASRS has kindly coordinated with the AIOS so that we can do a session with all the speakers here. The first talk is by Dr. Vishali Gupta. She's going to start the whole session with her topic on tips and tricks RD in retinochoroidal colobomas, and then we'll go on from there.
Thank you. Thank you very much, Manish. And as already mentioned by Manish, it's really a pleasure to see friends again and not staring into the screen and speaking. So the topic that I shall be talking about are the tips and tricks for doing RD surgery in coloboma. Now, before you actually take up a coloboma patient for surgery, this is the kind of the classification which you should know, and it generally tells you whether it is involving the optic nerve, whether optic nerve is abnormal associated, so it's good to know about it. Now, this is the only retinal surgery where I feel it's not about just do it. It's more about you have to know the applied anatomy and the structures and what you are doing and why you are doing that, So for this, applied anatomy for retinochoroidal coloboma plays an important role. Just a few things. I'm not going to bore you with anatomy, but it's just there is an incomplete closure of embryonic fissure. So what does that cause? That causes a split in the neurosensory retina. RP is redundant. Neurosensory retina gets split into two. And those two layers are the inner neuroblastic layer, which is commonly called intercalary membrane. And that is just a very abnormally thin retina. And the other one is the outer layer, which is neuroblastic layer, which is fused with the RPE. So now you have a coloboma patient sitting in front of you. What are the concerns? The first thing is try to find out the break preoperatively. And since the intercalary membrane is very thin, it's just atrophic, there is no contrast. The breaks that are located in the intercalary membrane are not going to be easy to identify. So you will have to spend some time there. So look at the coloboma margin. The retinal layer will continue from there onwards as intercalary membrane. And the zone of the adhesion is the point of least resistance, and that is why you will hear the term local minoris resistant. So this membrane is very taut, and I'm going to show you in video how taut ICM can be, which causes traction on the retina, and this transition zone is very important because the breaks may be located somewhere here. So how do you go about it? First thing, there are three possibilities. One, there is a coloboma which is just sitting there quietly, not contributing to RD, and you have a usual RD due to a peripheral break. Now, if that is the scenario, just ignore the coloboma and manage it as you would have managed that detachment without coloboma. The second scenario is this is the area where this is the local minoris resistance, that's the margin between the coloboma and retina, and this is the area where you will have to find the breaks, and believe me, it's not easy to locate these breaks preoperatively. So only thing you can say is, well, the peripheral break is not there, the RD is probably due to coloboma. You may be able to find the breaks within the intercalary membrane, which are relatively easier to find, and they may be staring at your face sometimes. So if you have these two, then this detachment is related to coloboma. And very rarely you may have both the things. There are breaks in the coloboma and breaks outside. Now, as I mentioned, the tip number one was the identification of the break, which could be in the periphery, which could be in the LMR, or which could be within the intercalary membrane. Now, besides your clinical judgment, what instrumentation can you use? Well, you can use OCT, but you have to have a patience bringing the OCT to a point where you are suspecting break, and if you are fortunate, you may be able to find this break and locate it either in the intercalary membrane or at the locus minoris. But for that, you need a lot of patience and getting the OCT scan passing through that particular line. The second is before you actually begin surgery, and this is the surgery done by one of my fellows, Atul. So before doing the surgery, if you are suspecting a break somewhere, you pay attention. Now he was suspecting the break to be this. So you can actually zoom your microscope, and you, if like we have MIOCT, you can use it, but even if you don't have, it's okay. So you can zoom and you may be able to see a slit or a hole in the intercalary membrane, which you are able to identify before you actually start doing surgery. Now you have started the surgery. So what are the tips? In cerclage, there is no definitive advantage, but if you have a peripheral break which you want to cover, sure enough, but otherwise there are no do's and don'ts about putting the cerclage. PVD induction can be tricky, so you got to be firm, but you have to be gentle, because I'm going to show you in next video that retina in these, I don't say children, but in these patients tends to be very mobile. So when you are doing very forceful PVD induction, you may have the retina coming into your port. And also many times the vitreous may be in layers. Again, I'm going to show you in the video that you have to look for the schisis. Very importantly, I will talk about fluid gaze and laser edges later. Now the first thing about anatomy which I said is that you have coloboma here, you have intercalary membrane, and you have a break in the intercalary membrane. Now what is happening is that you have the hyaloid which is attached at locus minoris, and a part of hyaloid is also going over the coloboma. Now that hyaloid is something which is very difficult to differentiate from the rudimentary retina, because when you are on top of the coloboma, everything appears the same. So for that, when you are putting the, he's trying, you can see, putting the triamcinolone, you take out the triamcinolone as much as this, and whatever the residual triamcinolone, as you will see here from the video, that after removing the triamcinolone very nicely, both over the coloboma as well as at the margin of the coloboma, then you try to find where possibly the edge of that hyaloid could be, which is extending, because if you put your forceps here directly trying to pull it, you may pull off the intercalary membranes along with it. So that might become an issue. You don't want to do that. That's not your aim of the surgery. So what you do here, from the edge, you can see from the edge the hyaloid can be identified. Go along the hyaloid, and this part of the hyaloid which is over the coloboma, that has to be taken off. Only then this rigidness or traction would go away. And then this is the video I would like to show you about mobility of the retina. Now you can see we have done core vitrectomy. We have injected triamcinolone. You see, this is the mobile retina, which tends to jump into your cutter. So you have to be very sure as to when you are removing the vitreous, you are doing it, the word is firm but gentle. So don't go on a very high suction, and don't go too, aggressive about it. Inject triamcinolone second time, even if you think you have removed it, because the vitreous can be very adherent and it can be in multiple layers. So even if you have removed the first time vitreous, you can see here there is another layer of the vitreous which was not coming with the cutter. So you may have to use forceps or anything to separate this second layer of the vitreous, which again you will use your cutter to nicely shave it off from the surface of the retina. So you can see, go close, remove it, make sure there is nothing, because this is the problem in these children. The fourth tip which I was telling you was the fluid gas exchange. When you are doing fluid gas exchange, you will have the ballooning of the retina, because you may not be able to identify small breaks in the local minoris. I will just take one more minute. And you can see here, this is where the break was, and when you apply your suction here, the fluid starts draining out, and of course you can later on drain it through the intercalary membrane also. If it's not draining, there is fine to make a retinotomy and drain through it, but by and large you'll be able to drain through the primary small breaks. Laser is important, and there is, they say you laser the entire edge, even if it's involving the foveal edge. To be very honest with you, I have never had a heart to treat the fovea, even if the coloboma was at the edge. So I reserve it for the second surgery if these patients require. And this is, you can see, this is the patient pre-operative. You can see this detached retina, and this is post-op. You can see I haven't lasered it here. I just don't feel like killing the fovea. So to conclude, the knowledge of the surgical anatomy is important for retinocoloboma surgery. So only difference I see between this surgery is actually simpler than many other complex diabetic surgeries and all. But only thing which I feel and I teach my fellows is they have to know the anatomy. They have to know what they are doing, what they are cutting, unlike rest of the retina where it's just do it. Thank you very much.
Thank you, Dr. Vishali. So I will invite our next speaker, Dr. Manish Napkal. He will talk on the management of large submacular hemorrhage. Yes.
I would not use PFC. Yeah, I would not. So that's why you have to spend a lot of time in, because there is coloboma, then there is taut intercalary membrane, then there are maybe large breaks in the intercalary membrane. So if PFCL goes behind this, then you create a mess. So by and large, you generally do not need,
So I request Dr. Vishali to come and take this chair here. So meanwhile, may I ask you some question, ma'am? Yeah, sure. Yes. Like if the break is somewhere within the macula and the macula is partially involved in the coloboma, will you do the laser in the macular area or close to the fovea?
Yeah, if I see the fovea is knocked off, I'll do the laser. I will just go very gentle laser burns there. But if it is really involving the fovea and the fovea is already gone, I will do it. But if I see that yellow pigment and fovea, I just go juxtafoveal. I know it should be done through the fovea. It's just, I don't feel like doing it.
And what is the power setting?
Power setting is about, mine would be very low, say about 100 to 150 micron.
Okay.
A bit larger burn and a very, very mild gray burn closer to.
Okay. My second question is, are you routinely using PFCL if the break is at the periphery, not at the posterior pole?
For colobomas, I prefer not to use PFCL.
Okay.
So thanks. If I can ask one, very nice presentation with excellent resolution. It's a difficult surgery. And I think, I don't know if here in the audience, how many here are going to do these kind of surgeries in the future. But one question which may be relevant for them is coloboma with no retinal detachment. What would be the indications for laser, and when would you do those cases for prophylactic laser?
Raja, again, we do not have level 1 evidence to say whether to laser or not. LVP group like Subhadra has published doing the laser to the coloboma without detachment all across helps in reducing the recurrences, but there are other published reports also which say that laser of the coloboma does not really make a difference. So for me, it would be doing a good peripheral examination to see there is nothing else going on. The second step would be, is there a RD over the coloboma, because many a times we may have a localized RD involving the coloboma.
Intercalated detachment.
So
Yeah,
you're
intercalary.
asking of prophylaxis or during surgery?
No, no, he's
No,
asking
prophylaxis.
prophylaxis.
So personally, even, I mean,
I don't
as a
do.
comment, I never do it.
I never do
because
it.
As Vishali said,
I
you know,
don't
we
do.
have a soft corner for the fovea and macula.
Yeah.
And if you're going to leave that much area barren,
Then it doesn't make a
actually
difference.
doesn't have much, and there's no evidence to show that it has reduced. So,
Yes.
So I think many people probably have lasers. They
Yes.
might be willing to do laser to
Should
as a
not be done.
prophylactic laser barrage. But
yeah.
some of my considerations include if the ICM is already lifted, there
Yes.
is going to be a break which may or may not be. So if you have an ICM break, intercalary membrane break, or a detachment of the ICM, I would go. And if the other
Yeah.
if patient is one-eyed, I don't know when.
That
the
is what
patient
I
is,
was
Yes.
going to say, that you look within the coloboma. If there is a detachment, then you may consider, but otherwise if coloboma is nice and flat, I will not
Yeah,
Yeah.
but the
place it.
ICM detachment is not easy to pick up in initial stages. You need to learn it slowly with experience. But
You
thank
can
you
use
so much.
OCT.
Yeah,
OCT
Yeah,
works very well
absolutely.
for ILM.
absolutely. But thank you so much, Dr. Vishali.
Okay,
Thank you.
Dr. Manish, please.
Thank you very much. I'm going to talk to you about management of large submacular hemorrhages. And when we look at hemorrhage occurring subretinally over the macular area, the classic way to treat it is usually with anti-VEGF gas positioning, and it works well for a certain variety of cases like you would see here. And over a period of a few weeks with the tamponade, the hemorrhage would go to the periphery and clear off. But doesn't happen that easily with a thick blood like this. So you need to differentiate between the type of cases that you come. If it's a more flat looking blood, you could resort to those things. But if it's a thick collection, that almost always leads to something like this. If you just keep waiting on it, sitting on it. This is the other eye of the same patient that I'm showing you a video of. So in these cases, I surgically go in and do a large retinectomy in the periphery. So first remove the hyaloid as far as possible, because you're going to do an invasive surgery and you don't want PVR and other things setting in. So stain with triamcinolone, make sure the hyaloid is identified well so that you can do a good removal. After that, just to test if the blood moves, put in some PFCL, but as you can see, it is so rigid, hard, clotted that it doesn't. So start with the peripheral retinectomy, almost about 200 to 270 degrees based on the size of or extent of the hemorrhage which is present. So diathermize mildly some of the larger vessels in that area and then cut it. Then remove the PFCL and then evert the flap from the retinectomy, just like you would see a giant retinal tear. That allows you a direct view, direct access to this thick clotted blood, which otherwise is extremely difficult. So you make sure that you get access to this whole plane. Gradually with the forceps, you can atraumatically take the retinal flap away. You could use bimanuality, you could use chandeliers. Multiple ways could be done to atraumatically get access to this hemorrhage. And as you can see that by moving the cutter, all that hemorrhage gets dispersed, removed. The thicker part takes a little while, but usually today's cutters can remove all this clotted blood quite effectively to a large extent. So you can see that slowly that whole area clears off, that whole thick collection of blood which was there. And once you're sure that is gone, then you revert the flap back with using the perfluorocarbon, just like a giant retinal tear. And now you can see that the retina is going back and there is that thick collection is gone. All you see is some pigmentary loss, which obviously is going to be there because that's where the whole membrane which had triggered the whole episode was, and then you treat it like a giant tear. So this is how it looks like in a month's time. I first presented this in 2016 at the Whale meeting, and then we did a lot of cases similar to this. This is another one, a large one, thick one, which required a similar sort of management. First remove the vitreous, especially stain it with hyaloid, because these are cases where you want to make sure that everything is clean, because any residual vitreous with large retinectomies, with blood, all this invites a lot of PVR in the long run. So do the same process, peripheral retinectomy in relation to the quadrants of the hemorrhage. So you customize it to the area where you see the hemorrhage and go a few clock hours beyond, because you need a bit of relaxed area for the eversion of the flap. So the same strategy we use, get access to the plane directly, and you can see that bimanually I'm trying to evert flap with one side and remove, and then put the retina back like a giant retinal tear. So these are patients who do recover back easily about 636 to 618 vision. Of course, they have a central loss of receptors, which is going to be there. And then there are these slightly smaller but thicker sized hemorrhages. So this is a separate variety which are not extending to the periphery but are thick and not very thin. So these are cases where I do a posterior smiley retinectomy, not an extensive peripheral one, and then remove it just like we used to remove the small subretinal hemorrhages in the past. That is an art we've given up earlier when the anti-VEGFs came, but I think it still helps us for cases like these, because these also end up with thick scars otherwise, these kind of membranes. So here also do a good vitrectomy, and then as you can see I identify this area just within the vessel arcade, and do a very mild diathermy, and then bring my cut rate down from 7,500 or a 10,000 to just 100 cuts a minute. So you can imagine the cutter would go just cut. So it's in your control, it works like a scissor. It's easier to do this with the cutter like this rather than use any other instrument. You could use a scissor also if you like, but it's just that these cutters work almost as good as a scissor, and with a very low cut rate you can control it like a scissor. And then it gives you access to the plane like that. The smiley shaped incision actually gives you a larger surface area, and you're also following the vessels. And then once you engage the whole mass of the hemorrhage membrane, which is usually coagulated onto itself, it with a gentle rocking manner would come out. So you can see that whole, you're engaging it with high vacuum on one end, and then very gradually just getting it out, and it delivers as a whole, this whole tissue, and then of course eat it up with cutter. So what remains is a smiling macula at the center, and then do a very mild laser to that edges, and then put gas and positioning. So this is what it looks like on follow-up. You can see the fovea is not as bad, and you see the incision on top, because during surgery you saw it at the bottom, but it's basically superior, and the fovea is pretty healthy. This is how it looks like. This is a case I just did 1.5 months back, and other eye of the patient already had a disciform scar with a similar hemorrhage, and the right side is what the patient presented with 2 days of history. And we posted for surgery with a similar, exactly the same kind of procedure. And once again, after doing the whole vitrectomy, hyaloid removal, plan the incision in this area. So you do it, the placement of this is based on the bulk of the blood and where you can easily access it ergonomically based on your own ergonomics of which hand you use or which instrument you prefer. You could change it. So this is what I follow, the same principle here. And then once you have that incision, and of course the size also you have to slightly consider in terms of the extent and make it accordingly. Otherwise, when you bring it out, it could sometimes enlarge or expand. So make sure you have a well relaxed incision when it comes out, and the whole complex delivers. And so the membrane as well as the blood would all come out together in toto with this. The fovea behind is clear of the blood now. This is the 1 month follow-up. You can see that there is pigmentary damage to the center, but which is part of the process which is there. You cannot do away with that. But otherwise, these people gain back reasonably good vision to move around quite soon. Otherwise, it takes a lot of time with all that scar and the central scotoma, which can be quite cumbersome. A few different cases. This is a case I took for doing a large retinectomy. But when I went inside, I saw large choroidals also once I cleared up the vitreous hemorrhage component of it. And because of the choroidals, I resisted doing a large retinectomy because then it would have been too aggressive and may have caused more inflammation. So in this case, I just did subretinal injection of air and then did air fluid exchange, how Tamer Mahmood, I think, had presented some cases like this, and left it with subretinal air bubbles and an air-filled eye. And because of the choroidals, if I make retinectomies, it may cause more bleeding or damage, so I had to change my plan inside. And it did gradually clear up centrally. This is the early pictures after a week or so. And so this is something you need to modify if you have a situation like that you also see extensive choroidal activity. Then maybe you should not do a large retinectomy in those cases. So these are some of the surgical steps that I use, customize it for a few set of patients which have a thick hemorrhage over the macula. Sometimes it's extremely large, which warrants a large retinectomy, and sometimes it's within the arcades, but it's very thick, and I don't think will come very easily with the use of just gas and positioning. Thank you very much.
Thank you so much, Manish. This actually,
Yeah.
You're using a cutter to do retinopathy.
Yes.
Don't you think that will lead to some loss of tissue?
yeah, this is actually Subhendu's territory also, I'm sure. He can give his own presentation on this.
Yes,
But yeah, so Manish.
Yeah, so basically you're right. So you could use a scissor also, but these cutters are so fine and you go with a small cutter and you're almost going in obliquely that technically it just makes it very simple instead of trying to maneuver a scissor. But you could do a scissor, you're right. I mean, you might save a little surface area, yeah.
So Manish, the excellent videos and compelling case, like,
Thanks.
you would make everyone believe that I can go in tomorrow and
Actually, all it does is disperse. I think it just takes up, it just occupies a certain space, and because vitreous cavity now also has an air bubble, it's air filled, so you give prone positioning, so that is pushing. But just with the stuck up blood, sometimes it's not able to move it, while here the bubbles are also by themselves moving. So Tamer Mahmood has presented a series of these cases. Of course, he also uses TPA along. Some people use, So various people use mix and match. I've not had a great experience with TPA, so I'm not a huge fan of TPA. It almost always brings about a vitreous hemorrhage afterwards, and you might have to go back in again at times. So I prefer
so
clearing
that's the big question, Manish, in the sense, at least for some of those limited within the arcades,
Yes.
there have been multiple publications of just intravitreal
Yes.
TPA. You do get vitreous hemorrhage, you can clear it out later on, but you don't have to manipulate subretinally. And there are some cases where you may want to give a subretinal TPA, either just subretinal TPA and air and leave it, or drain it, give it some time to liquefy and then drain it in the same surgery. But at least the big ones where you had kind of exudative hemorrhagic detachment, large ones, you have to many times drain them out. But the ones which were limited within the arcade, I don't know, Dr. Vishali, what are your thoughts?
Subretinal TPA with air, we are doing it a lot.
Yeah, so that's something less dramatic.
Yeah.
I used to do.
Everybody cannot do it like Manish.
There's so many ways of.
We are complimenting.
Everybody
They're
has their own
He's
modifications,
an artist,
like
yeah.
subretinal TPA or subretinal TPA plus anti-VEGF plus air.
That's right.
Non-drainage
Plus
technique, and if it is larger enough, so you can do the retinotomy, 2 paracentral retinotomy that can remove the
even
blood, but
BSS
not
works.
not the CNVM part.
Actually,
but you
before
can do the
era
peripheral
of
retinectomy.
anti-VEGF, we have done so many subretinal membrane removals that
Yes.
this is
You're
actually just
tempted.
an extension of
Yes.
that. It's rightly, Earlier
Yes,
the better.
also-
It
also,
only
yes.
works in the first few days to a week, I think.
14 days
After
is
that,
the
it's
usual guideline.
Not
Yeah.
beyond 4 weeks.
earlier the
Before
better.
fibrosis,
Yeah,
once
yeah.
there is fibrosis.
Yeah.
Thank you so much.
Yeah.
Now I
So,
Dr. Subhendu
thank you
Bolakia.
ASRS for inviting me to present in your in ASRS symposium in AIOS DreamCon AIOC 2022. I will discuss regarding the complications in macular renal surgery. Macular surgery means during or just after macular surgery. A lot of unwanted happenings may happen in intraoperative period or in postoperative period. So these are all some unique cases may happen. So how are you going to manage in these cases? Like first, in a case of macular ERM, simple macular ERM, we turn to retinal detachment. Like in this case of macular ERM, it is quite well visualized. So I did all peripheral retinectomy, vitrectomy followed by injecting dye. When just after injecting dye, I saw that macula is beginning little bit becoming little boggy. So I have seen there is a track of fluid going to the periphery. So just I started doing peripheral. I just started doing removing the ERM from the macular area. And when I was removing the ERM from the macular area, my field was I am working on a case of CSR, just like that. But before that, there was macula was absolutely flat, and I just completed the ERM and ILM removal part. Just after that, I have seen sudden retinal detachment intraoperatively. So what should I do? Retina is almost like retrolental. You can see the subretinal layer is coming inside, just behind the retina. So I injected PFCL to check the periphery, and I have seen there are peripheral breaks in the infusion cannula area. I removed all the vitreous and started doing fluid exchange, settled the retina, and did laser at the end of surgery. All around 360 and silicone was injected. My infusion cannula site was almost 4 millimeter, maybe 4.1 millimeter, but this kind of unprecedented happenings may happen due to the anterior insertion of ora serrata. That was my take home. This is another case, intraoperative macular hole formation. That is submacular surgery. That after clearing is a case of submacular hemorrhage. I have injected subretinal TPA, but what was my mistake? It was I was very close to the fovea. I have given first subretinal TPA, followed by cocktail of subretinal anti-VEGF as well as air. And I've just seen that there is egress of blood coming out through the macular area, that is from the fovea. That means iatrogenic macular hole formation. So what should I do? So I was little bit perplexed because in the subretinal space, there was air, anti-VEGF, all TPA, all my efforts will go if we drain all these things and do inverted flap technique. So I did just drain from the macular hole little bit, hold the macula was boggy enough, completed the fluid exchange and SF6 gas, but I was fortunate enough that macular hole was closed in post-op period and vision finally improved to 6/18 after 2 months. But not every time you will be fortunate, because it was a case of partially old vitreous subretinal hemorrhage. I tried this technique, but postoperatively I seen a small macular hole, and the subretinal space you can see there is still blood is present. After 3 weeks, patient came, vision dropped down to 1 feet, finger counting. So my management plan was ILM peeling the ILM and with the inverted flap. That is the minimalistic approach, what I should say. I have checked the macular hole part. I don't have intraoperative OCT to see the actual position of the macular hole. So I stain the ILM and peel the ILM and just invert the flap just over the macular hole area. Not all around, because it is a secondary macular hole. It's not the idiopathic macular hole, what we used to get, and try to put this flap just overlaying the macular hole area. Drain little bit, blood was not there. So my whole flap was just overlaying the macular hole, and postoperatively the hole was closed. After 2 months, vision improved to 6/36. So this is another case where intraoperative tear was detected during macular hole surgery. It was a routine macular hole surgery with inverted flap technique. So it is a very old video. I started the flap, creation of flap with the help of Tano scratcher. And just see, I completed the whole peeling all around the macular hole. And finally, I used to, I have to keep the flap overlaying the macular hole. I used the Tano scratcher as well as the silicone tip rectus needle. Just see, there is loss of iron flap. So I used Tano scratcher again, just reposit the flap overlaying the macular hole. Just see, tear happened at the macular hole margin. So don't use Tano scratcher for the reposition of the flap. What should I do? I waited for some time, let the clot to be formed and put the whole clot over the macular hole area. And post-operatively, you can see the macular hole is closed. And from all section, you can see the tear margin is hardly visible. So after 4 weeks, it is closed. Intraoperative foveal tear formation during subfoveal PFCL removal. Another very unwanted happenings that happened. That was, you can see the subfoveal PFCL vision was 20/120. You can see the thin ILM overlaying the PFCL margin, and you can detect it is not fluid, it is PFCL because of, you can detect the omega sign that is present in case of subfoveal PFCL. You can see the PFCL margin, and it should be acute, not the obtuse. In case of subretinal fluid, the angle should be obtuse, but in case of subfoveal PFCL, subretinal PFCL, the angle is acute because of the strong surface tension of the PFCL bubble. And here, after removal of this silicone oil bubble, because I have to perform the surgery after removal of silicone oil, just see there is jerky movement. That means the anesthesia effect was not good. The small jerky movement, I should have stopped it, but couldn't stop during the surgery. With the help of 41 gauge metallic cannula, I tried to remove this subfoveal PFCL. See that there is bleeding, that means tear happened. I was not sure that whether it is tear or it is just a puncture of the retinal facial. So I did subtenuous anesthesia on table, stopped my surgery. And after total anesthesia, total akinesia, I removed the PFCL, and PFCL bubble nicely come out. Remove the PFCL bubble. Now the tear is there. That means tear is there. So again, I did stain the ILM and did inverted flap technique to cover up this hole, that tear area. So these kind of unprecedented happenings may happen during the surgery, and you have to use your presence of mind. Just I covered this tear area only, and post-operatively you can see the hole is nicely closed and vision improved to 20/40. Now, post-operatively open macular hole is another situation where the primary surgeon has done the routine conventional macular hole surgery, not inverted flap technique, and hole was open. He did two procedures, one standard macular surgery followed by SF6 gas injection, and vision was 20/200. So in this case, I planned for the ARG, that is autologous retinal graft, and choose an area of supranasal area of the disc, from the disc, and just injected subretinal BSS to make a blob, and injected PFCL just go beyond the donor site, and use gentle cautery to separate the graft from the surroundings. Now I used Finesifex loop to separate this graft from the donor site and harvested this graft under the PFCL, that is Finesiflex loop assisted graft transfer under the PFCL in a controlled manner, very much controlled manner. You can just put it over the whole area and remove the PFCL. First do the fluid exchange, taking care of the meniscus of the PFCL bubble because it is convex, then followed by silicone oil PFCL, direct silicone PFCL exchange under the Sangen's light, injecting silicone with the left hand and removing PFCL with the right hand, And post-operatively, you can see after 3 hours of surgery, hole is closed. Nicely, it is getting the contour of the fovea. After 2 weeks, vision improved to 20/80. So, thank you.
Thanks so much, Subhendu. In fact, there is a lot to learn when someone shows their complications. We
Yes.
actually tend to learn a lot.
I must
to keep
compliment
our
you
minds
to
open.
show so many of these things which I think all of us make these, but to show them requires a lot of courage.
Yeah. So let's
Thank you.
start. If anybody has questions from the audience. The last case we went to macular graft, I mean the retinal autograft. So how do you choose the location? Because we know that obviously the photoreceptor density and their further synaptic connections with the bipolar cells. The farther you go away, the visual acuity potentially, what you can give back to the patient becomes very less. So how do you choose the site of the donor for the retinal graft?
So ARG is not my invention. It is actually described by Dr. Tamir Mahmood and Dr. Grewal in 2014-15, I think so, in San Francisco. ASRS, they first presented their cases, and they choose just above the superior temporal arcade or inferior to the arcade. Superior arcade they are preferable because of patient prone positioning is not that much is required, and you will not see the postoperative retinal detachment also. I choose supranasal area because farther it from the macula, and it can prevent the further macular ER information. That is my purpose.
Anybody else has?
Otherwise, the synaptic regeneration of the graft, it is very difficult to explain. But I think you have to take care of the upside down. That is which one is ILM side, which one is photoreceptor side. That is.
I have published in my retinal autograft multifocal ERG,
Yes.
fluorescein angiography, and even I had to go in for some other reason, and then there were tight adhesions between the donor and host junctions.
Yes.
They just really like a fibrotic junction they form, and there were responses on the multifocal ERG in the central ring also. So there is the patient
Yes.
had
Yes.
I'd say 20,
We have done the
28 vision.
MFERG. Yes.
So the thing is, yes, they do have functionality, but if you want to really improve, so beyond a certain visual acuity range, you probably, we have to see how closer we need to go to the, macula and get a graft from there. If you want 612
their
vision,
explanation was, Dr. Tamir explanation was just it will act as a macular plug, and slowly from the graft margin and the donors, recipient margin, that retinal layers regeneration take care with the help of molar cells and other cells. So that will slowly develop. And definitely it is better than the amniotic membrane graft. That I did also, but ARG is superb. It is better than the.
I think amniotic membrane is just too avascular. This one has vessels which makes it easy to form the connections and the adhesions with others.
yeah, amniotic
but
membrane is just
yeah.
a scaffold.
It's
I mean,
just a
that's-
scaffold.
I think apart
Even
from
clot works like that. Like he showed one of the patient's clot. It's just a fibrin glue coming from the clot, which will work very well, as a scaffold.
So, but apart from that case, I think the other cases which he showed that any kind of a macular work that you're doing with the peeling or something that you're finally doing, I think the biggest thing which one has to keep in mind is good visualization. You need to be seeing it extremely well stereoscopically with whatever viewing system you use. Without that, never compromise starting the peeling, because if for any reason your media is not great and you think there's a compulsion to do it, that's when sometimes you may pinch deeper or whatever. All these things can happen if the visualization is not good, apart from other things. And of course, the always checking for that peripheral inferior detachment or a break. Very common whenever you do PVD in any case. In cases which have PVD, it's unlikely, but where you do a PVD induction, always look inferiorly for any ooze of a hemorrhage or anything which is not looking right, and make sure you laser that area at the end, and it would prevent a detachment eventually. So I think these two are very important for all
Yeah.
macular surgery.
Yeah, I
And
think
also while injecting anything, whether it is a dye or a PFCL or something, don't ever direct it towards
Yes.
the fovea, you
Yeah.
know.
We-
Initially, sometimes you forget, so you just push
Mm.
the syringe. It can be quite detrimental.
In fact,
Yeah.
talking of the syringe, also make sure when your assistant gives it to you, you check it outside.
Yeah.
Sometimes
Yes.
whatever content, especially triamcinolone, other things can get stuck.
Blocked.
And you may forcibly inject it and
Push it
it
and-
may push.
that's called jet stream injury.
stream.
There have
Yeah.
been numerous cases.
is
Can
another
cause injury.
But what Dr. Nagpal mentioned is so important that as beginners doing just retinal detachment, vitrectomies for simple vitreous hemorrhage, our depth of focus is not as much as we should be having for, let's say, a macular surgery. And even if you have a little bit less resolution, you can still complete a good surgery for
Yes.
retinal detachment or diabetic vitrectomy. But if you want to do macular surgeries, submacular surgeries, your resolution has to be so good
Yeah.
that probably you are able to see the individual nerve fiber layers.
Yeah.
You can see their arrangement. That's what the magnification you should be having when you're doing these macular surgeries.
Because I can tell you very clearly, I mean, there are certain cases which midway I would just leave the peel because there may be a multifocal lens which is, something is not right, the focusing, or there's a PSC which I've overlooked and is bothering me, and I would just stop it and do all the other things and leave the peel because that's when you create those
Becomes,
extra
yeah.
pinches.
Thanks again for Dr. Subhendu. What his cases have shown is we should not be doing, learn from his cases.
Yeah.
Okay.
There are questions, Raja. Yeah, yeah.
What visualization system do you particularly prefer for macular work? And the new Ingenuity, do any of you use it? I mean, does it add to this whole scheme of getting
I use Ingenuity all the time, and it works very well for macula. But as Manish said, that don't make it an issue to do it in one go, because you have started peeling, and just then you will realize that it's not as clear as it was, which could be due to fogging of the lens, which could be your instrument hitting the lens, which could be due to so many other factors, something coming in between. So take a moment, look at the things again, and then go in. I think Manish used to use macular lens and maybe still does,
Me
but I
also.
use
I use a
Ingenuity.
contact flat lens actually. All macular work is on a flat lens. Simple that, you know, the one which was on irrigating now has flanges. Grishaber makes it, Vogue makes it. Yeah, self-retaining. So those give you very crisp stereoscopic view.
And you do have colored channels on Ingenuity, so if you want to look at some particular layers, you can just switch the color channels, which make the epiretinal membrane stand out and all.
Sometimes what happens, even the patient is pseudophakic and there is no PC rent, so you are doing under fluid exchange or peeling. There is sometimes just after injecting BBG or any dye in the vitreous cavity, the dye may come through the journals into anterior chamber. That you have to check whether your AC is getting blue stained or not. That
Yeah.
makes your media hazy.
Thank you so much. In the interest of time, we have to move on. If we have time, we'll come back to you for questions. So, over to you, Daraz.
Thank you, Dr. Raja, for that. So I'm going to just present, it's going to be in the form of movie, some interesting cases which presented to us with endogenous fungal endophthalmitis post-COVID. So I'll just play the movie.
In early 2020, the COVID-19 pandemic hit us like an avalanche. Medical science battled to save lives with every measure available. However, many who made it through the blizzard had ramifications which were felt in various parts of their bodies later. We present a series of patients who developed fungal endogenous endophthalmitis after ICU stay for severe COVID-19. Each of these was a challenge to manage, especially as they had been initially misdiagnosed due to the varied manifestations. This patient lost vision 2 weeks after discharge from the ICU and came to us with a total retinal detachment and inferior retinal abscess. During the vitrectomy, we removed fluffy white fungal clumps, debulked the inferior retinal abscess, and peeled the PVR membranes. Superonasally, the membranes were very tight. We dissected these bimanually with our forceps and the light pipe, and then trimmed them with a cutter. The retina settled and silicone oil was injected. The material removed from the retinal abscess grew Candida albicans. At the end of the surgery, we were surprised to find episcleral creamy white material, which we dissected and sent for histopathology. These turned out to be refractile crystals of a periocular triamcinolone acetonide steroid deposit. This patient was initially diagnosed as non-infectious uveitis and loaded with steroids of every form. We administered intensive antifungal therapy. The endophthalmitis cleared and the retina was stable post-operatively. The next case was a surgical challenge as he presented with a detached retina and a huge fungal granuloma behind the crystalline lens. Since the granuloma was very anterior, a lensectomy was performed. The retina was covered with white snowflake-like fungal elements. We dissected the nasal area of traction and then cauterized the granuloma. This portion needed a relaxing retinotomy to settle the retina. Once attached laser was performed, post-operatively he is doing well. Our next case was diagnosed elsewhere as diabetic macular edema and was referred to us for anti-VEGF injections. We noted CME on the OCT but surprisingly found a yellowish creamy lesion superonasally in the fundus. We treated her with oral and topical voriconazole. The CME resolved and vision improved. However, 4 months later, there was fibrosis in this area causing a tractional retinal detachment. We placed a belt buckle and tried to release the traction bimanually. Then we delineated the fungal granuloma with the cutter and cauterized its surface. Post-operatively, the retina is stable with good vision. Our next case was initially diagnosed as Neovascular Amd, but as he developed vitreous exudates, he was subsequently treated as a case of uveitis with steroids. We suspected fungal endogenous endophthalmitis and performed a vitrectomy in both eyes. In the right eye, we removed the creamy white exudates. We noted a yellow fungal abscess at the posterior pole. In the left eye too, we removed the exudates from the vitreous cavity. Then we realized there was a small fungal abscess at the posterior pole along with 2 large subretinal fungal abscesses in the periphery. We cleared the vitreous cavity, did a fluid air exchange and put in silicone oil. The vitreous sample grew Candida albicans. Despite all our efforts, the left eye was lost. He was on oral and topical voriconazole for 9 months. The right eye was infection-free for 1 year when he presented to us with a hypopyon that again grew Candida, and the eye worsened with a large fungal mass in the AC. He required a revitrectomy with IOL removal and oil injection. The retina is now stable, but this case makes us worried that the snowstorm can gather strength and attack us again. After weathering this fungal snowstorm, we felt it was important to spread this information to make the medical community aware of this issue. We made an infographic for all our medical colleagues. We also appeared on national television and a leading newspaper to spread caution about this and also promote rational use of steroids. But ours were not isolated cases, and more such cases were subsequently reported from across India, including a series of 33 eyes from South India. The Indian Journal of Ophthalmology published 2 editorials on this topic. So it seems we had only seen the tip of the iceberg. It is important to be aware of this entity and to have a high index of suspicion of endogenous fungal endophthalmitis in post-COVID patients who have been treated with systemic steroid. We recommend a fundus examination of patients on intensive steroid therapy for severe COVID-19, especially in those with any visual complaints.
Yes, any questions from the audience? So there is, what kind of protocol did you follow in these patients once they had the endophthalmitis? How aggressive were you with them?
So I think that's a good question, because most of these had been, as we saw, diagnosed as various other entities. So by the time they came to us, it was in a quite a fulminant stage. Most of them were PL/PR. So we did vitrectomy for all these patients. But Dr. Arja, I think LVPI has the largest series. In fact, we just published 7 eyes, but yours has 33 eyes, which came from LVP. So
Yeah,
did you also
so
have any change in protocol? Because
No, in the sense, yeah, in fact, our IGO paper has got one of the awards this time for that publication. And Samira from our Vijayawada campus was the main author, chief author for that. So while we would, in general, for such cases, we are aggressive with our vitrectomy. When we say aggressive vitrectomy, normally it's recommended that you have, such patients, you don't go in for a complete vitrectomy. You just do a core vitrectomy, give intraretinal antibiotics, cut the losses in the sense you don't want to cause iatrogenic damage in these cases. It's not easy to see. You go in, everything is white or yellow, but we in our cases we use options of endoscopic vitrectomy or keratoplasty along with that. But in what we would try to achieve is as much as possible, including going for peripheral vitrectomy in these cases. That's the meaning of aggressive
I
vitrectomy.
think we did it as complete a job as possible. We could not just do the classical teaching of just do core and inject, and it would not work for these cases.
Yeah, but some of these patients, when they presented in the acute phase, they had an ICU setting. I mean, they're just being kind of from the ward, COVID ward, shifted to, and their oxygen saturation is low. And in that kind of setting, we couldn't do that kind of aggressive vitrectomy. We just had to do a tap and antibiotics initially. But when the patient's condition stabilized otherwise, we went in for a full vitrectomy in this case. So that's the overall difference that we have, that we need to be aggressive in these cases.
Yeah.
Doctor, yes, I have a question. Like, are you preferring injecting silicone oil in this type of cases because the fungal endophthalmitis that recur usually?
Yes, I think especially if there's any suspicion of breaks or any detachment, we have a high threshold. Some of them we have not injected.
Or cyclitic membrane?
Or cyclic, because there's a high chance of hypotony also. One of the patients lost. So those eyes, definitely oil is a good option.
I think there is another important thing is many of these eyes were not as fulminant as they were made by corticosteroids with the wrong diagnosis of uveitis. Autoimmune variety of the uveitis itself is very common in post-COVID era with different phenotypes. So whenever you are in doubt, look at the glow. It's a very simple test. If you have a yellow glow, there is no uveitis, howsoever severe it may be, will produce a yellow glow. So if it's a yellow glow, don't start the patient on steroids. Just take up right away for vitrectomy. And the vitrectomy in such scenarios should not be only therapeutic vitrectomy. It should be a diagnostic vitrectomy as well. So you should have your cytopathologist, molecular biologist, immunopathologist if available, and everything in place to look actually what is the kind of inflammation you are dealing with. If you get fungus, well and good, but it may not always be fungus. It may be something else. So you will get a huge information from that vitreous samples.
Wonderful. So we go on to the next presentation. Dr. Rajanarayan is going to talk on pars-plana vitrectomy with dexamethasone implant for epiretinal membranes.
Can I have the slides, please? once again, I thank the ASRS for giving us the opportunity to present some of our work. I'll be talking about pars plana vitrectomy with intravitreal dexamethasone implant for epiretinal membrane management. So when we give the DEX implant, this is during the surgery of ERM removal itself. It's not a separate stage of procedure. So when we are doing the vitrectomy, do the epiretinal membrane removal, we give the intravitreal dexamethasone at the end of the surgery. And I'll go through why we had this hypothesis. And so I do not have any financial disclosures. Yeah, so epiretinal membranes, there can be numerous causes for ERMs. Something wrong, I don't know.
Some sync.
It's going off again and again. Should we change? Again, it's gone. किसी और लैपटॉप में डाल दूँ?
Dr. Tamir and Dr. Grewal described it should be 1.5 times more than the size of the hole, I think so. And I usually take 1.5 to 2 times because graft shrinkage. That yes, in respect to the size of the hole, what I measured preoperatively, and measuring the disc diameter is the only fixed structure in the fundus. So because while placing the graft over the macular hole, I just insinuate little bit gently into the macular hole so that it can take the contour of the fovea, and later on the graft shrinkage can happen. So compensating all the factors, so it should be 1.5 times at least, or you can take the 2 times also.
So you insinuated
Okay. No, not insinuated. Placing the graft over the macular hole
okay.
and just make a dimple over the
Okay.
macular hole center. Under PFCL. That will be make the, because they describe 2-stage surgery. I am doing 1-stage surgery. They are keeping the PFCL for 2 weeks. Then again they're doing siliconal PFCL exchange, and later on they are removing the silicon. That means 3 surgery. First surgery with PFCL, second PFCL siliconal exchange, third is removing PFCL siliconal with gas exchange. So I am doing the single surgery followed by silicon removal. That is 2, sir.
So, but what Stano described for these myopics with amniotic, he's doing, he's putting it PFCL and then straight away switching to gas in the next one. That is the other way that they do, I think. Yeah.
I did 7-8 cases. So in one case I placed graft displacement, and I redid the ARG, and that is now hole is closed. I removed the silicone oil after 6 months, and again did the ARG. Just it was in the just above the disc, and I did in the nasal area.
All my macular hole cases, especially long-standing macular hole ones, I use that to slightly circumferentially massage it a little bit. It's like a atraumatic, what you would say, an external indenter. It's in the size of a 25 gauge size. So it's something like that. So just a bulbous tip which is totally smooth, and you gently massage it 360 degrees so that a little bit of elasticity is gained by that usually. Redundancy comes back faster. No, I just go all 360 degrees with that massaging it. Yeah. No, I mean anything except for the ones which you are seeing as stage 1A or 1B where you have a hyaloid sticking in. Those I don't use because they close very easily with the hyaloid. But beyond that, yeah. All right, Raja. Yeah, please.
Sorry about that. So I was mentioning about the hypothesis that idiopathic epiretinal membrane can have an inflammatory component, but more importantly, whenever we peel epiretinal membranes, there are cases where the vision actually is worse than the baseline visual acuity when we started off the surgical planning. There is an increase in the edema on OCT in the first few weeks, and also the visual acuity can drop post-operatively before it starts recovering. And various studies have shown inflammatory cells in peeled epiretinal membranes as well as ILM. So our study was published in the Indian Journal of Ophthalmology a couple of years ago, where we did a comparative study of pars plana vitrectomy with or without intravitreal dexamethasone implant. We enrolled 30 patients in the study. The inclusion criteria were patients with idiopathic ERM, age more than 40 years, visual acuity between 2030 and 2400 with an OCT thickness of more than 300 microns. Patients could be pseudophakic or phakic, but if the cataract was significant, we performed cataract surgery at the same time as the ERM surgery, and the duration of the disease with symptoms should be less than 1 year. So this is the baseline characteristics which were matched between the two groups. If you look at this graph of visual acuity, you can see the control group on the top, and the red line is the study group with the dexamethasone implant. There is a worsening of the visual acuity compared to where you start off with in the control group where we did not give dexamethasone implant, and then gradually the vision improved over 6 months in those eyes where we did not give the dex implant. Whereas in the eyes which received dex implant, by first month itself, the patients had achieved what more or less they were achieving at 6 months. So the recovery of vision is rapid if you were to do an ERM removal along with the dexamethasone implant. So the point is that, as I was mentioning, in ERM removal, sometimes after the surgery, the vision is worse, and it's very embarrassing or difficult to explain to the patient. We set off to at least maintain the vision, but patient is having worsening. And typically for ERMs, the counseling, when we talk to the patient, we say it will take a few months, sometimes even up to 6 months for you to recover or stabilize. So adding dexamethasone implant, we felt that we were trying to improve or shorten the course of recovery for these patients. We will also show the backup anatomically how the OCT also changed in these cases. Again, the gain in vision by more than 15 letters, that is 3 lines, was also more in the study group, although overall the final vision was not too different between the two. Central retinal thickness, again, as you can see here, while there was a reduction in the control group without dex implant, it was a slow process over 6 months, and even at 6 months it was still more edematous than those eyes which received the dex implant. So you see a rapid reduction in the central retinal thickness. By 1 month you are achieving what can be maximally achieved in these eyes, both visual acuity wise as well as OCT thickness wise, whereas if you were not to give a dex implant, it takes 6 months or more for these patients to show improvement. And this is a figure which we published. You can see that in the eyes without dex implant, the edema still persists over many months, 1 month and 6 months compared to the study group. So this is a video of a patient where we gave the dex implant at the end of the surgery. I'll show the technique may not be that simple, or initially you may have challenges how to give the dex implant at the end of the surgery. So a standard 3-port pars plana vitrectomy has been done, and then we are removing the epiretinal membrane. In these cases, I tend to also remove the ILM after staining. After peeling the ERM, I stain the ILM and remove the ILM. although in that particular study where we published, we did not remove the ILM specifically in those cases. So again, after the ERM removal, we stain the ILM with brilliant blue, peel the ILM in a standard fashion. Because these are epiretinal membranes, you don't have to do an inverted flap or any of those modifications. You just do a standard ILM peeling, and I do a fluid air exchange before injecting the intravitreal OZX implant. So I remove one of the cannulas, and then at the end we inject it, and you can see it nicely resting over the optic disc. This is one patient whom I operated recently, 68-year-old gentleman based in UK, but he's of Indian origin, but came to India, Hyderabad, because there's a long waiting time there for surgeries, especially ERM. He had a thick ERM, vision of 2160. This is the OCT angiography, showing a lot of artifacts, but no significant ischemia, at least in the superficial layer where there's not much of an artifact. And then at 1 month, there is a significant reduction of the edema in this patient with 20/100 vision. So these patients, wherever there is edema, and not just a fine ERM with no edema, I do not tend to inject OZX. But when there is swelling beyond 300 microns along with ERM, in those cases, I do inject these cases. So this is another patient where I did cataract surgery along with epiretinal membrane, and at the end of fluid air exchange, you can see the OZX floating in over there. So in conclusion, the long-term visual outcome and reduction in retinal thickness was similar in both the groups. However, the time taken to achieve the maximum gain, that is the recovery time, was significantly shorter in the DEX implant group. So DEX implant at the end of ERM surgery can hasten the visual recovery. I would like to acknowledge my colleagues Surabhi, Dr. Cooperman and Hasnath, and also thank Retina faculty for this. Thank you so much for your kind attention.
Thank you, Raja, for such a nice presentation. I have a question. While injecting this Ozudex injection, I think in last year, ASRS, they have described the path of the Ozudex implant that moves it's a trajectory. The path, it moves like a hyperbola because of the vitreous cushioning effect. That will not hit the, what is the velocity of the intravitreal Ozudex injection in a non-vitrectomized eye? But in a vitrectomized eye where there is no vitreous cushioning effect, while injecting the Ozudex through the sclera, that will not move through the trajectory, that will directly may hit the opposite side of the retina.
Yes, so that's something I've been storing my video recordings whenever I inject OZX after vitrectomy. Unfortunately, the video kind of went off at the end when I was injecting the first one. The second one was different slightly. So yes, the OZX, it goes in a different trajectory, and then it just settles down flat over the one. So the first time I injected about 3 years ago at the end of vitrectomy, that's when I realized that it has a different trajectory. But what I have started doing is I do a partial fluid air exchange. I don't do a full fluid air exchange. A partial fluid air exchange at the end, between the air and fluid interface, it stops there. It doesn't even go to the retina. So it just floats over there.
Yeah, so I think that's an extremely important point because I also use it a lot post these surgeries, and at the end of a vitrectomized eye, and I normally go into a full air fluid exchange for other surgeries, and here after doing that, if you inject, I've had cases where it goes like a missile and hits the retina, although it didn't traumatize it, but it just looks
so
as
in
if
this
it may hit
video at the end, if you see, this is floating at the air fluid interface, so that's a better way to give a cushion in these patients.
So the other thing is always point the trajectory inferiorly or some not on the posterior pole, and I've also realized that if you press it very gently, it actually goes slowly. It's not that it goes with the same speed. If you press the button very slowly, it will actually come out in a slow manner. So it's better to do it in these cases like that.
Absolutely. Okay, thank you so much.
All right, thank you very much. I think we've run out of time also.
One more thing, like you can do complete fluididex and give triamcinolone acetonide at the end of surgery under FG, or you can compare with this triamcinolone acetonide with Ozurdex. That is.
There have been studies on triamcinolone. Yeah.
Yes.
Okay.
Yes.
Yeah, it just
Yes.
comes out like a snake.
Snake. Huh.
Yeah. Yeah. Because earlier I used to think that it won't make a difference, but then somebody told me that if you press it very gently, it will come out, and it does. Come out slowly.
But
Yeah.
no, that is the non-vitrectomized eye. Vitreous is giving the resistance. Yes, but in a vitrectomized eye, there is no vitreous.
No. So he's talking of the pressure on
Pressure.
the
Pressure,
So if you do it slowly, it will actually come out like a snake.
snake.
Yeah.
Yes.
Yeah.
Yes.
Yeah. Absolutely.
Thank you. So we are ending our symposium.